So I was asked to talk about the role of ctDNA in bladder cancer. I know we touched upon this quite a bit since the beginning of the day, but I will just give a quick overview. So I'll talk about a little bit about what is the definition, the characteristics, and the different platforms that are available, what are the clinical applications to this date, the studies that ctDNA has been used in some ongoing trials, and then I think it will be great to go over some unanswered questions. So it's interesting, and I'm glad we have a pathologist in the room because I feel as medical oncologists, it's interchangeable. We talk about CTCs, cell-free DNA, MRD, tumor biomarker, and I think we lump all these in one big kind of lump, but it's not exactly the case. So I think we all need to understand and actually define what we're ordering. Another interesting point we're saying about positive or negative, but we haven't realized that actually there is a rapid clearance of that ctDNA. I will call it ctDNA for the rest of the talk. But the half-life is short. So you can have clearance within from 15 minutes to 2 hours. So, you make a test before chemotherapy or after chemotherapy or after surgery, you really don't know what you're testing because it's a dynamic change. So, at the same time, we try to identify some cancer cells in their circulation, but there are different platforms. Some they're checking the methylation status, some RNA, some DNA. At the same time, as years evolve, newer companies and now AI are coming into play, and they come to the clinic and they start advertising that they have the best available platform. They can use it for free. They will charge the insurance. They will not charge the patient. And again, being Greek and touching base with my Greek colleagues, over there, everything is expensive. Like to order an Atera, it's about $4,000 or euros. So, and that's for one-time test. So it becomes really unethical to me that, I will test every single patient if I want to in my clinic, and I cannot test my relative, in Crete. And all these make us realize that we don't know what we're ordering, we don't know what tests we're getting, but our goal is how can we identify micrometastatic disease? So how have we seen this technology being used? We do it to see if we can identify cancer early, and oftentimes, especially in the adjuvant setting after neoadjuvant chemotherapy, if you have early detection, you may actually have early intervention. You may give nivolumab based on that. At the same time, early detection is not the opposite of lack of detection. But if you don't identify micrometastatic, you may not treat the patient, so you can prevent them from the cost, you can prevent toxicity. And then we have been talking all this morning about biomarker. Is really ctDNA prognostic biomarker? Or does it really help us understand a scan? So there are times that we do imaging, especially in patients who received immunotherapy or a disease, and you see something in the lungs, and you say, is this disease? Is that infection? Is that pneumonitis? And then you go from a negative ctDNA to a positive, and you say, maybe actually you start having some recurrence. So sometimes can be complementary or confusing to the imaging. We try to use it to monitor treatment response. And what I have found interesting, and we have done even more in prostate cancer and kidney cancer, when people progress, you try to get biopsy and try to look kind of clonal evolution and see, can we find mutations, alterations, and personalize the treatment? But where I think is really helpful, and we're just talking with Dr. Lenahan during the break, that ctDNA can be helpful when we don't have tissue. So there were some studies showing if there is concordance between ctDNA and matched tumor tissue, and actually 85% or a little bit less than 85, you may be able to identify what is in the tumor in the circulation. But there are times that people can have metastatic disease and their ctDNA is completely negative. And what comes down to is not all cancers are the same. And you cannot always depend on a ctDNA to assess if someone has cancer. So you can see that depending on the histology, you can have different expression in the circulation. So, we just talked about the Volga trial. Dr. Petrikal was describing. When the Volga trial started, the FDA demanded to have a safety run-in trial. So we had 17 patients that received at least one cycle of durvalumab, tremelimumab, and enfortumab vedotin. And out of those 17, 14 actually underwent radical cystectomy. So it was interesting that we had the ctDNA status, and in the beginning, 62% of patients were positive and 37 were negative, but after the 3 cycles of durvalumab, the negativity increased to 78%. So 7 out of 10 patients had actually ctDNA clearance. And we're able to find that 5 of those patients actually had pathologic complete response. So from positive to negative was correlating with pathology at the time of surgery. And those that were positive and remained positive, actually they were upstaged. And then it was not a surprise to see that those with ctDNA had a better event-free survival, while all the patients with ctDNA positive after cystectomy actually died. So Volga is completing accrual by the end of the year, and we're collecting specimens throughout the study. It's going to be almost a 700-patient study, so hopefully we'll have more information and see how can we use this to determine should we change the treatment after the neoadjuvant portion and the cystectomy if patients continue to be ctDNA, and that's something we discussed earlier today. Moving on to a study that many of us participated, and that's how actually we start thinking about ctDNA in bladder cancer. This is the IMvigor 10. So just to remind everybody, there was a study where patients who received neoadjuvant chemo and didn't respond or refused chemotherapy were randomized to atezolizumab or observation. So you can see here that that study was negative in a way atezo did not improve disease-free survival. But then going into a subgroup analysis, we found that those patients that were ctDNA positive actually had poor outcome, but atezo improved their disease-free and their overall survival. On the flip coin, patients that were on the observation arm, if they were ctDNA negative, did better versus if they were ctDNA positive for both disease-free and overall survival. So that's where we're actually using ctDNA as a concept, is this prognostic. And people come to clinic and say, okay, I have my chemo, I hated the MVAC, you gave me surgery, I have all these infections. Now, am I gonna die from this? Did I go for surgery for no reason? And that's where you hope that this biomarker may help you and reassure them that you do have a chance, that you went through all this for good reason and you may be cured, but of course, you need to continue to be monitored. Now, fast forward, when the atezo and the IMvigor 10 study was negative, obviously, looking through the subgroup analysis, Genentech went back and said, well, if we think that atezo can improve outcome in the ctDNA positive patients, let's redesign the study and select only the ctDNA positive. So that study also completed accrual recently, but just to remind everybody, patients that were ctDNA positive were randomized to atezo or placebo, while those that were negative just continue standard of care, which is surveillance. Now, it's interesting that this study was designed about 5 years ago, and as it was opening, especially in the US sites, nivolumab got approved in the adjuvant setting. So it was unethical for a ctDNA positive patient to enroll on the study and actually put them on placebo. So I think Nivo really hurt IMvigor 11 for that specific reason, but the majority of patients were outside of US. And while the study is not, we don't have all the data yet, but Tom Powell just presented the population of the ctDNA negative patients, and actually what he presented is that actually within 1 year, the disease-free survival is down to 92%, and in 18 months, 88%. So that goes back to negative predictive value and all those concerns. So someone can walk in and be ctDNA negative, and still they have a good 12% chance of having recurrent disease. So clearly, it's not gonna be a perfect marker. Now, the study we have discussed a little bit during the day, that I think all of us that we have the study either in our institution or in a close-by institution, we should try to support. This is the modern trial, it's through Alliance, and Dr. Galsky is the overall PI. So the goal is for patients who did not respond to neoadjuvant chemo or refused neoadjuvant chemo will be randomized in cohort A and cohort B. So for those who are ctDNA positive, will get either nivolumab or nivolumab relatlimab, which is the LAG-3, that this combination is approved in melanoma. And for those patients who are ctDNA negative, they will still get immunotherapy with nivo, or they will undergo surveillance. Now, what is very interesting is that these arm 4 patients will continue to be monitored every 3 months, and at the time they develop ctDNA positivity, actually they will have a chance to go on immunotherapy then, which I think is very interesting what is going to happen to those individuals. So if you start treatment early, when you start identifying disease, can you improve their outcome? With all that, I think we have more questions than answers, and things that will be great if we all discuss is, does early detection means shorter survival? And is what we said earlier. If you have circulating cells, does this mean you're going to die? And if you find cells and you start treatment, are we over-treating? And how early is too early? Because again, treatment comes with toxicity, with financial toxicity, definitely increased anxiety, and I don't know who is more stressed, the patient, the relatives, or the doctor. But when we get those tests, we need to do something about it. And then another question that again came up earlier today, how long should we treat patients? So if someone has ctDNA clearance, should we stop treatment? If we treat for like 6 months or 18 months and they went from positive to negative, is that enough to say, your scan is negative, your blood is clean from cancer, let's stop? And last but not least, I think we need to work with our experts, engineers, technology, pathology, to try to find what is the best platform to use. So I think there is hope in the future that we can start seeing the invisible and make the impossible possible. Thank you.